Fact, your smartwatch may know your heart rate, but does it really know you? A new Georgia Tech study says many of today's health algorithms are built for the so-called perfect patient, someone with money, time, and flawless routines. But here's the catch. Most of us, we don't really live like that, right? Well, let's dig into this. Whether technology meant to help keep us healthier actually leaves some people behind. We've got Catherine Wieczorek, one of the Georgia Tech researchers behind this study. Catherine, great to see you this morning on The Take. Okay, so let's talk about this idea of the perfect patient. So who is that, and why could this be such a problem?
Hi, nice to meet you. Thanks for having me. So the idea of the perfect patient, what we're really doing here is looking at how AI is changing healthcare, not just by making it faster or more accurate, but changing how we ourselves think about our health and how even doctors and nurses do their jobs. So for the perfect patient, they're living in a few different possible worlds, and one where this perfect patient might be wanting to live in a world without disease. And in this vision, AI isn't just waiting until you get sick. It's constantly scanning for risks, stepping in early. For instance, programs that use chatbots to check in with expectant mothers, where the technology is collecting data from prenatal tests, flagging possible risks, and offering support. And the promise with the tech here is that no mom or baby should suffer from problems that could be prevented. And here, the perfect patient would be an expectant mother that's using this technology. And this interaction is really powerful because it can prevent some negative health consequences, but it also assumes that people want to turn to this tech. They know how to use it, they know how to interpret the results, and that they want to use this rather than talking to a doctor or nurse. So what we're looking at is that there's some assumptions that how these AI models are created truly represent the lived experiences of a wide variety of women and their pregnancy journeys, and that the mother truly wants to use this technology.
Okay, well, Catherine, a lot of us, wear smartwatches or we wear the fitness trackers. How might those devices possibly misinterpret the health of someone who might be juggling multiple jobs or caring for kids, or they have a chronic illness?
Right. So looking at, what kind of data actually goes into how these models are created. If you're doing a job with heavy lifting, that could or could not be represented in the data that's used to kind of interpret the data that goes into something like a smartwatch. And in our study, we look a lot at how some technologies specifically phrase disabilities. If you're wearing like a smart eyeglass, that could potentially enhance your vision, but also kind of assumes that you as the wearer wants to be seen with perfect vision, or that's your perfect model for how your body should work, rather than kind of embracing how people with different disabilities want to actually live and be in the world.
So what do you think are the biggest risks involved if we keep building these types of tools around the perfect patients instead of the real ones?
So we're not saying that AI in healthcare or health devices is bad. It's actually doing a lot of good. But I think what we're trying to get at is really behind the tech, there are hidden choices about what we value, how the data and how these tools are created, and therefore how much we can kind of actually trust the outputs. And more specifically in the healthcare systems, if patients are being evaluated based on data and their data outputs rather than interaction with people, it's not only changing the outcome for the patient, but it's also changing how healthcare works, how doctors and nurses need to respond to this data rather than interact with the patient. So it's not so much that we shouldn't outright not trust them or not use them. It's more about thinking critically about how this is changing how we interact with each other and how we think about our own health and what this data can actually tell us.
Yeah, that's important to think about. Any ways that you think that the tools could perhaps be redesigned to better reflect kind of something you alluded to, the realities of working parents, older adults, and people who have maybe some of those disabilities?
Yeah, so technologists are often working very hard with the data they have to kind of innovate on these new exciting technologies. And, one of the best things we can do is try to think more expansively about the data inputs and how the models are created could represent larger samples. So Often historically, especially in women's health, some of the hallmark metrics, such as like a pap smear, long historians of technology have shown that these data sets and this actual evaluation was trained on a particular type of women, often white middle class. And so any data, the pap smear is actually skewed towards that range of women rather than a more pluriversal group of women. So Arrest's recommendation, and not just me, many other critical technology researchers argue that the data should be more inclusive of different women and different people. So trying to create those data sets so that these models can be approved and attuned to a fuller range of people that the technology is intended to serve.
Yeah, it really is something to think about. Catherine, we appreciate you joining us this morning. Thanks so much.
Thank you so much.